So welcome everybody. This is Bob Figlin, the Steven Spielberg Family Chair in Hematology Oncology at Cedars-Sinai Cancer in Los Angeles. And I'm delighted today to, on behalf of the Kidney Cancer Journal, to have a roundtable with some distinguished investigators with great experience in the use of Tivozanib, both in the clinical and research setting. So let me welcome Bob. Can you tell us about your current position?
Yes, thanks, Bob. I'm an attending physician and the section head for the kidney cancer section within the Department of Medicine at Memorial Sloan Kettering Cancer Center. And
Tony, welcome.
Thank you, Bob. I'm Tony Schwery. I'm the director of the Lang Center for GU Oncology and at Dana-Farber in Boston, and also in Boston, professor of medicine at Harvard Medical School.
And Laurence.
Thank you very much, Bob. So my name is Laurence Albiges. I'm a medical oncologist. I'm head of the medical oncology department in Gustave Roussy Institute in France.
So what wonderfully distinguished group of people to discuss the role of Tivozanib. So Dr. Motzer, Bob, let's start with you. You are a pioneer in the development of tyrosine kinase inhibitors in kidney cancer, have really great experience in that space. And why don't you help us understand where Tivozanib, a VEGF receptor TKI, fits in that spectrum and the clinical trial that resulted in its approval in second-line therapy patients that had received prior therapy?
Well, Tivozanib is a highly potent and selective inhibitor of VEGFR2, and it was developed at a very exciting time in our studies in kidney cancer between 2000 and 2010. And at that time, there were several different VEGF TKIs that were developed, and some of which were approved. And so one of the outstanding attributes of Tivozanib, in addition to its efficacy, was its tolerability and lack of really off-target toxicities that we saw with some of the other approved TKIs like sorafenib. So it was originally studied in a randomized phase 3 trial called the TiVo-1 trial, which did result in approval in Europe, but not in the United States. And this led to the TiVo-3 trial, which was a large randomized phase 3 trial of about 350 patients, in which Tivozanib was randomized against sorafenib in patients who were heavily pretreated. Patients had 2 or 3 prior treatment programs, including a TKI, and including some patients who had progressed on checkpoint inhibitors. So that study, met its primary endpoint by showing improvement in progression-free survival compared to sorafenib in a more heavily pretreated population, as well as a similar overall survival, and really a improved safety profile, which is a hallmark of Tivozanib, with fewer grade 3 or 4 adverse events, particularly those that are most troublesome to patients, including hand-foot syndrome and fatigue.
So Tony, let me turn to you. I mean, one of the hallmarks of the last several years that you've been such a leader in is really combination therapy for kidney cancer, which has changed really the hallmark of what we're offering, whether it's IO-IO or IO-TKI. So before we get into some of the clinical data with respect to outcomes, help us understand, when you combine a TKI with an IO, are they additive? Are they synergistic? Are there effects on the tumor microenvironment that make those combinations better than either of those drugs alone? Help us understand kind of the preclinical platform for that combination.
Yeah, Bob, I mean, overall, I can tell you that beyond seeing if there's a synergy or additive, effect, we are combining 2 drugs. Each have a single agent activity, both in frontline and the refractory setting. So it does make sense to combine them just from a totally situation that makes sense. And that's really the easy part. Now, having said so, we know that in preclinical models, T-cell mediated cancer cell killing, which is how immune checkpoint inhibitor largely works, may be enhanced through, if you want, reversal of VEGF mediated immunosuppression at multiple ways in the immunity cycle. For example, promotion of T-cell priming and activation through the maturation of dendritic cells by inhibiting VEGF, that could happen. Normalization of the tumor vasculature so that T-cell could infiltrate the tumor better. You know, an immune permissive tumor microenvironment can happen by decreasing the Treg and the MDSC that are bad immune effector cells. All these can happen by reversing VEGF inhibition. We cannot say today, based on the clinical data of the combination, that there have been synergy or this is simply each drug alone is acting, but at least preclinically, it makes sense to combine them, not just because each one works on its own, just because of this body of evidence that exists with both classes of drugs.
That's quite a nice summary, Tony. Thank you. So, Lorenz, let me turn to you. You're the first author on the Ty-Nivo trial. It's the phase 1b/2 trial that you've reported. So dive into that trial in terms of what you did, the patient populations that you studied, the outcomes that you observed, and why that pivotal early trial has led to a larger trial in the phase 3 setting.
Thank you. So it's actually building on the two previous development from Bob and Tony on the rationale that we have two potent, one VEGF TKI and one immune checkpoint inhibitor that demonstrated strong single agent activity, that the rationale was to build in. And Tony highlighted that there is also a rationale to combine these two from an immunology standpoint in terms of the ability to those two drugs from a theoretical standpoint to synergize. So on this rationale, and also because also other combination similarly were developed, there was the launch of a phase 1 combining Tivozanib. Two doses were actually tested, 1 milligram and 1.5 milligram at the regular scheduled use, meaning 3 weeks on, 1 week off. And those treatments were performed in combination with Nivolumab at the standard 240 milligram every 2 weeks. So that's a phase 1. Overall, 25 patients have been treated as part of this phase 1. What I can tell you from a clinical standpoint is that obviously the tolerability was great, meaning that Tivozanib, thanks to its potency, but also to the spectrum of this VEGF TKI, was actually quite manageable in combination. And the most frequent toxicity was high blood pressure. That's a toxicity that medical oncologists in the field of RCC have been exposed for many years, and therefore was manageable from a clinical standpoint. So overall, what this phase 1, which included 25 patients, so of course it's limited number of patients demonstrated, is that we were able to achieve a response rate that is 56%, but 80% of our patients had some degree of tumor shrinkage. And the disease control rate actually was 96%. So clearly a great signal of activity. With regard to treatment-related adverse events, it's in the spectrum of the one we are used to see, both with VEGF TKI and immune checkpoint inhibitor. And once again, the most frequent was high blood pressure. Therefore, it does require a close monitoring, but it was manageable from a clinical standpoint. Ultimately, the early sign of progression-free survival was very enthusiastic, above 18 months. So what we are used to see when we combine a potent VEGF TKI with an immune checkpoint inhibitor.
And Lorenz, I know that you published this. Do you have any clinical follow-up that you can share with us, kind of those 25 patients that you've observed either in your own clinic or you've heard about? Are some of these responses durable?
So the answer is yes. I could not speak for the entire study as it was a multicentric study in France. However, I can tell in my patient that we had seen very long sustained response, and that in some patients we ultimately were able to discuss treatment discontinuation. So clearly what we're seeing is a great disease control.
So Bob, before we turn to Tony and talk about the phase 3 trial, I think it's important that we circle back and talk about quality of life with Tivozanib. And I know that you've reported on some of the Q-TWIST data, and we've all come to understand the safety profile of Tivozanib in the clinical setting, but summarize some of the objective data that you've reported on. You're on mute.
So we did do an analysis looking at PRO comparisons in Q-TWIST from the TiVo-1 trial. In those analyses, they take into account time on drug, they take into account progression for your overall survival and adverse event profile. And so in that direct comparison to sorafenib, there was improved scores, and it would appear to be improved quality of life for patients treated with Tivozanib compared to sorafenib. I think that is, I think in part, the safety profile is, one of the greatest attributes of Tivozanib, and the lack of, many of the side effects that are associated with the deterioration in quality of life, including fatigue, including anemia, including hand-foot syndrome. Those are all adverse events that really tax on patients, and that we see with some of the other TKIs, particularly with sorafenib that was compared to, but also sunitinib and some of the others. And those side effects are I wouldn't say minimal, but they're certainly less than what we see with some of the other multi-targeted TKIs.
Thank you, Bob. So Tony, let me turn to you. So you're the first author on and have published on and part of the TiNivo-2 trial. So help us understand both the goals of that trial, and also share with us, one of the areas that we're most interested in as kidney cancer experts is really what is the role of IO after prior IO, and how that might offer our patients some continued immune modulation that helps them with positive outcomes. So help us understand where you think that trial fits, what the goals are, what the objectives are, and how you think that will help us answer the question of IO TKI after prior therapy.
Yeah, I think this is a very important unmet need. That's why we launched the study TiNivo-2 in this population based on the quite encouraging data with the study, the original 25-patient study that Dr. Albiges just mentioned. So based on that, we said to ourselves, where is the unmet need? And one of the unmet need is patient whose tumor progressing after prior immune checkpoint inhibitor. As we know, combination IO-VEGF were mostly done almost uniquely in the first line untreated setting, these randomized studies that led to approval of these combinations. So based on that, we launched TiNivo-2 that is open to accrual, where patients will be randomized to Tivozanib as the standard, and the experimental arm will be the combination of Tivozanib plus Nivolumab here. Patients should have received at least one prior, but up to 2 or more prior lines of therapies, including an immune checkpoint inhibitor. Patient also, not surprisingly, should have had a clear cell renal cell cancer, and they could have had any IMDC risk factor. The one thing I want to mention here, bringing back the question of hypertension, Again, that is a hallmark of VEGF inhibitor, perhaps with Tivozanib potentially, or the combination of Tivozanib and Nivolumab, higher. So the dose here, when we combine Tivozanib with Nivolumab, is lower than the single agent Tivozanib here. It's 0.89 milligram overall. So the goal here is to find a niche of this completely unmet need and see if adding Nivolumab on a backbone of VEGF TKI here, Tivozanib, will result in improved outcomes.
Yeah, I think we all recognize, and you're to be congratulated with your colleagues, because I know Lorenz and Bob are part of that study, for answering that critical unmet need. So let me just go around the table and ask each of you. I mean, we've accomplished so much in kidney cancer in the last 2 decades through the era of the tyrosine kinase inhibitors, now the era of the immune checkpoint inhibitors. Where do you see us going from here, Bob? I mean, I know that many of us are looking at triplets, which is, a couple decades ago, we would never have thought would have been things that we would ask in kidney cancer. And here we're trying to combine it with agents that inhibit HIF2 inhibition, for example. So how do you see the field evolving that you've been so seminal in developing?
Well, I think that, for one thing, identifying novel agents with novel mechanism of actions is important. I think, one such class of drugs, which Tony has been pivotal in terms of bringing forward, are the HIF inhibitors. And so we are, that as a class seem to be very well tolerated and combined well with others. There is a study with belzutifan plus cabozantinib that looked pretty good and promising, good tolerability. So I could see HIF inhibitors combined with this particular combination as a next step. I also think that with positive results from this trial, I'd like to see this combination moved up front to patients. I think it would be a good first-line program, and I'm even a advocate for a study of a combination like this, even in the adjuvant setting. I know TKIs as single agents certainly didn't pan out in the adjuvant setting because of, for one thing, poor tolerability. But I think that Tivozanib may have a better stand in that, and also in particularly a combination with Tivozanib and a checkpoint inhibitor, to me, would be very attractive in the adjuvant setting as well, based on the high level of activity. So those are some of the areas. I mean, I think others are a better understanding of underlying biology, and see if we can identify kind of who is going to respond best to what particular program.
So Tony, without putting you on the spot, but putting you on the spot, you've articulated nicely an increasing role of immunotherapy in the high-risk resected population. And here we are talking about IO TKI as second line after prior IO therapy. How do you think the field's going to evolve if there's an increased uptake of checkpoint inhibition in the high-risk resected population? And what do we do next?
Absolutely. And this is why we need studies in the post-IO setting. Now, the study, the T-Nivo2, which we talked about, ad nauseum here, does allow prior adjuvant treatment. So hopefully we'll have a subgroup to see if prior adjuvant treatment, if IO given in the prior adjuvant setting is the same. I tend to believe it will not be different if the progression happened within a year. Of course, if within many years, then that's probably a slightly different biology. But I think, if the strategy is successful, then we have to look now that we have a drug approved in the adjuvant setting at the same construct as the design of T-Nivo2, but strictly in the adjuvant setting. And that's something we've been working on, because what if the biology is different?
Absolutely. And Lorenz, just to close, one of the challenges that the 4 of us face is we still have to navigate through people with brain metastases, bone metastases, difficult disease. Any insights from your perspective on whether there are now evolving populations of patients that we need to be addressing because of unmet needs, as we've described with the Tynevo 2?
Thank you. I think it's a broad question. Obviously, we need to think about those patients that are difficult to treat. So I agree with you that there is an unmet need in terms of brain metastasis. And here we know the role of multimodal approach, combining stereotactic radiation therapy on top of our systemic treatment and maybe defining the optimal systemic treatment. It's likely that we may want to combine a VEGF TKI with an immune checkpoint inhibitor so that we would be able to induce more tumor shrinkage, for instance, here. You mentioned bone metastasis, but for instance, I would like to mention non-clear cell renal cell carcinoma that we shouldn't name as such. We should speak about those different entities where we clearly need to have more clinical trial being developed and test some of those combinations in this patient population that usually have very aggressive features. So there is beyond clear cell RCC, the challenge of those different clinical entity or also pathological specific tumors that need to be addressed. And I really feel that we have made a long way, but we still have a lot to go, and especially with how to sequence those different agents. And Tony highlighted the rescue strategy in patients would have failed after adjuvant space, for instance.
So let me just summarize by saying I think that my distinguished colleagues have identified the important therapeutic index of tivozanib, its toxicity profile, the rationale for combining it with immunotherapy, and asking the questions in a pivotal trial that has both adjuvant patients as well as systemically treated patients. I just want to thank Dr. Motzer, Dr. Choueiri, and Dr. Albajiz for taking the time and chatting with us today on our roundtable. Have a great day.